to our first session of the day. I'd like to introduce Amy Koch and Maria Nickel, who will be presenting for Salient Healthcare.
Thank you, Anna. Good morning, everybody, and welcome to Salient's presentation entitled Diving Deeper into Financial and Utilization Impact, an ACO cohort study of COVID-19 episodes. We are extremely excited to be sharing our findings with you as we've assessed data across over 100,000 Medicare beneficiary lives. Now, before I get started, I want to mention that at the end of the presentation, we're going to announce a keyword, and you're going to email us that keyword so you can be entered to win an Amazon gift card. Now, additionally, we're going to be sure to have a handout for you, and I believe they posted on the website, and that has just further information and details on the study that we did. I didn't want to share a whole bunch of tables on PowerPoint slides because that's never fun, but if you want to really dive into those numbers, you have that available. All right.
One of you has a speaker on. There we go. We should be good to go now.
Are you able to hear me okay? So, are you getting feedback right now?
Amy, now we can't hear you. Sorry, everyone, for these technical difficulties. We thought we had everything under control before we got started, but you know, it's 2021. This is what happens. We have technical difficulties with virtual conferences. Maria, do you want to take over from here while Amy gets situated?
Yeah, that sounds great. So I'm going to go ahead and introduce myself, and then I'll hand it over to Amy. So I am a senior business consultant with Salient Healthcare, and I have over 11 years of experience in healthcare operations and healthcare strategy. My specializations include process improvement and the application of emerging healthcare delivery models. And at Salient, I work as a liaison between our clients' needs and the developers creating the solution. Presenting with me today is Amy Koch, and she is a principal business consultant at Salient. She has over 11 years of experience in the ACO and MSO space, assisting in operation management in the shift towards value-based care. And as a team, we focus on continuous process improvement and are aligning our solution with the needs of the industry, which are constantly changing as the climate shifts down in the continuum towards value-based care models as well as payment structures. So next, we're going to go ahead and take a look at the agenda.
Hey, Maria, I'm going to hop in. I think I'm good now. All right, so looking at the agenda, we're going to cover the pre-2020, pre-COVID timeframe, and that's going to give you a baseline of information. We're setting the stage and providing contextual background. And then we're going to take a look as to what actually happened in 2020 and the impact that COVID-19 had on healthcare systems, followed by CMS's response to COVID-19 and how those adjustments were revised over time. Then we're going to share our findings from our cohort study and interpret them so that you can take a look as to how you might address 2021 and beyond. This is the story of the pandemic, and it's important to analyze the data to ensure we learn from our experiences. If we want to progress towards value-based care, then we need to constantly be thinking about what's on the horizon and where do we need to keep our eyes on so that our trajectory stays on course despite some of these hiccups that arise along the way. So with that said, I'm going to hand it back to Maria, and she's going to begin the story.
All right, so this is a graph that displays all the ACOs participating in MSSP year over year. And we can see that the number of ACOs is trending upward as more and more organizations are entering into value-based agreements. Now, similarly, the savings rate continues to increase over time as well as ACOs gain more and more experience with the program. These organizations are also earning a shared savings bonus and exceeding their MSR. In fact, of the 541 ACOs in the program, 241 of them generated shared savings totaling $1.19 billion in 2019. Their quality scores were also really high, with an average quality score across all programs ranging from 92.17 to 99.6. And in line with this graph, as ACOs gain more experience, they're more likely to generate shared savings. ACOs that have been in the program longer have a greater probability of generating savings and earning bonuses. Following a similar trend, the per capita savings rate increased over time as well. So for this presentation, we completed a cohort study of some of our ACO clients. I'd like to take a minute to thank each one of them. I'd like to point out that these organizations span across 7 states, and they represent a variety of organization types, including hospital ACOs, independent ACOs, and some were even FQHCs. As with most presentations, we'd like to set the stage with some preliminary numbers before the pandemic hit. So let's take a look at the 2019 data. For 2019, there were approximately 90,000 beneficiary lives that we analyzed. We compared these numbers to the MSSP cohort of 10.9 billion lives. Now let's take a look at how the Salient ACOs compared to all MSSP ACOs. This data is generated from the Salient solution compared to the annual expenditure and utilization reports provided by CMS. We're really excited and proud to report that Salient clients generated close to 2 times the shared savings compared to MSSP ACOs. Our cohort also had higher utilization and spend PMPY. So then the pandemic hit. So let's do a quick recap of what everyone here likely experienced. Starting in March, hospitals started shutting down and their elective surgeries due to capacity constraints and statewide mandates. I'm sure a lot of you saw this in your hospitals as well. In fact, Becker's Hospital Review had started a list of hospitals that were postponing elective surgeries, and then eventually that list got so large, they literally stopped updating it. And around the same time, nursing homes were also reacting. So, for example, many facilities limited the number of visitors. In fact, one of my very close friends was in an inpatient rehab facility, and we had to do what was called a window visit. You stand in front of the window while you're speaking to them on the phone. Nursing homes were not really prepared for the pandemic or quarantine, and they were some of the hardest hit when it came to caring for patients, especially with the staff constraints. Many hospital staff were also repurposed, and perhaps some of you were pulled into other roles as well. Lots of the support staff were charged with taking temperatures of staff, handing out supplies, and additionally, many care managers were tasked with following up with more vulnerable patients. Medicare fee-for-service in-person visits also fell for primary care in mid-March. Nearly half of the Medicare primary care visits were provided via telehealth in April compared to less than 1% before the public health emergency in February. Now let's talk about the patients. Many patients with chronic conditions were at risk for severe COVID-19. The CDC came out with a list of those that were at increased risk of illness, and you'll see many of the conditions that we frequently see in the MSSP populations were affected. And of course, the organizations represented here today were significantly impacted as well. We found a really great article that highlights some of your efforts from NACOs. You identified high-risk patients, reached out to them, implemented telehealth and remote patient monitoring to help with the continuity of care, and worked with patients on care transitions. And of course, there was also significant focus on nursing homes since many of the at-risk patients actually live there. So with all that going on, CMS had to respond. So let's take a look at how the policies unfolded. So prior to the waiver, Medicare could only pay for telehealth services on a limited basis when the person was living and receiving the services in a designated rural area, and when they leave their home and actually go to a clinic, a hospital, or other certain type of medical facility for services. CMS expanded immediately the use of the telehealth benefit. Under the new waiver, Medicare pays for office, hospital, and other visits furnished via telehealth across the country. And furthermore, they started to include patients' place of residence as of March 6th of 2020. A range of providers such as doctors, nurse practitioners, clinical psychologists, and licensed clinical social workers are now able to offer the telehealth as a benefit to their patients. Additionally, the OIG provided flexibility in healthcare providers to reduce or even waive cost share for telehealth paid by federal health programs. Also in March, CMS announced a new HCPCS code for healthcare providers and laboratories used to build the Medicare COVID tests. Also in March of 2020, CMS announced that it was granting exceptions for reporting requirements and extensions for clinicians and providers participating in Medicare quality programs with respect to upcoming measure reporting and data submission for those programs. There's also a quote from former administrator Seema Verma that, quote, in generating these exceptions and extensions, CMS is supporting clinicians fighting coronavirus on the front lines. The Trump administration is cutting bureaucratic red tape so that the healthcare delivery system can direct its time and resources toward caring for patients. In 2018, CMS established an extreme and uncontrollable circumstances policy for shared savings programs that apply to ACOs subject to extreme and uncontrollable events, such as Hurricanes Harvey, Irma, and Maria, and the California wildfires, elective for performance years of 2017 as well as subsequent years. The Secretary's declaration of the public health emergency for COVID-19 in January of 2020 triggered the Shared Savings Program's Extreme and Uncontrollable Circumstances policy for mitigating shared losses. The public health emergency for COVID-19 applies to all counties in the country starting in January of 2020. As for benchmarking, CMS allowed ACOs to opt into a fourth year of the contract, and the same benchmarking methodology was extended for that contract year. New applications were accepted for a January 2021 start. In December of 2020, CMS came out with an additional policy regarding COVID episodes. CMS adjusts certain shared savings program calculations to address the impact of COVID-19. They exclude all Parts A and B fee-for-service payments for a beneficiary's episode of care treatment for COVID-19 triggered by an inpatient service. Many of you have likely seen the attributed files with the new tab with the patients that had the COVID-19 episode. So with all of the changes that CMS had come out with, we enhanced our solution to accommodate these changes. I'm going to go ahead and pass it to Amy to discuss the changes that we made and how we used the system to complete an analysis of the impact of COVID on our clients.
Thanks, Maria. So I'm going to reiterate a few of those points. And as Maria shared, CMS had to make some calls to ensure that the program makes sense and that the extreme and uncontrollable circumstances were taken into account. As such, CMS created what they defined as that COVID-19 episode. And this is where CMS is flagging a patient who had an inpatient visit due to COVID and deemed any expenditures that occurred within that admitting month and those discharging months and everything in between to be part of that COVID episode. And they're actually removing those expenditures. Now, as a tech company who assists with a number of ACO clients, we had to adjust our solution to accommodate for this. But we wanted to ensure that we didn't just mimic what CMS logic is doing. We actually want our clients to be able to see all of their expenditures with and without those COVID-19 episodes, as well as be able to analyze them on their own. So within about a month and a half, we had our team push this enhancement to our users so that they could use a filter and be able to do analyses, as I just explained. And with these filters, we're able to complete our cohort analysis. So here on the screen, you're actually looking at a snapshot of our dashboards with those filters in place. Now, back to our study. We compared data across the same select clients on gathered information from 2019 compared to 2020, and we're looking at about somewhere between 90,000 and 100,000 lives. Now, let's take a look at some of those findings. We want you guys to have all that data, so we provided that handout if you want to take a look at it as I'm running through some of the findings. Essentially, utilization across the board decreased, and the largest decrease or movement was in inpatient utilization. And we suspect that this decrease was largely due to a decrease in elective procedures, but there's also the fact that hospitals were selective in who they were admitting because they needed to have room for patients who needed vents. Additionally, patients were more cautious of being in a setting that would expose them to the virus as well. So there's a few different factors that play into the decrease in inpatient utilization. The second largest category to decrease was in home health and skilled nursing facility utilization. And post-acute care we knew was going to be hit hard. We thought that skilled nursing facilities would have been hit harder than home health because it's just not a favorable setting for care because of the conditions that skilled nursing facilities were in. But nonetheless, home health had decreased more. And it's probably due to staffing and willingness of staff to even go into the homes of patients and risk being exposed during the pandemic. Now, there were some other findings. We saw that both ACO benchmarks and hospice utilization increased in 2020. And we think that the benchmarks pretty much increased due to higher utilization in 2019. So that's going to affect the 2020 benchmark. And this is great because, like I said before, we saw a huge decrease in utilization. So the decrease in utilization plus the higher benchmarks are going to lead to quite a few shared savings for those clients. Now, as for hospice utilization, this was somewhat of a surprise. We suspected that many patients who actually qualified for hospice sought out care in the home setting rather than a facility, and they saw that palliative care or hospice care might be the best option for them considering the pandemic environment. But we can definitely do further analysis as to why hospice utilization went up. Perhaps advanced care planning initiatives were put in place in 2019, which led to the use in 2020. There could be some other reasons as well. So let's take a look at the impact on patients who actually had the CMS-defined COVID episodes. And here what we saw was that there was some information that was to be expected, and there were a few more surprising pieces. Patients with COVID episodes had higher risk scores, and we assumed that because we knew that those who were at high risk were the ones who were going to be affected by COVID. And we saw that only about 1% of the attributed lives actually had the COVID episode. So a very small portion of the total attributed population was actually affected. Now, expenditures for those particular patients had a pretty wide range, but by and large, they were about 3 times higher than those patients who didn't have the COVID episode. Now, moving into utilization, we know that there was a decrease across the board, but specifically talking about utilization, we saw that only 3% of ER utilization was for those patients with COVID episodes, and about 6% was for those who had inpatient utilization. So I'd say it's like twice as many as what we would normally see for this particular population. We also saw that inpatient length of stay doubled for those patients who had the COVID-19 episode. Now, lastly, it's important to understand the beneficiary death rate. And of the patients who died across the cohort, about 5% actually had the COVID episode, which is comparable to the amount of patients who die from a stroke each year. Now, we're going to move into a deeper analysis on the patients who died who had those COVID episodes. What we did is we actually assessed the chronic conditions of these patients and saw that the top 3 chronic conditions these patients had were hypertension, chronic kidney disease, or CKD, and ischemic vascular disease, or IVD. Now, what we had thought is that this would probably align with the prevalence of those chronic conditions in the population, but it wasn't necessarily the case. Now, hypertension, sure, the most prevalent chronic condition in the population, and so here we see that it had the highest prevalence. But CKD and IVD did come as a surprise. We actually hypothesized that those patients with COPD would have had higher prevalence due to the fact that we know that the virus has a large impact on lung function and lung capacity and patients' just overall ability to breathe. So we had thought that COPD would have a higher rate, but it just wasn't the case. And we do suspect that those patients with CKD and IVD do have higher risk scores. Now, lastly, we set out to analyze telehealth because we know that this is the year, former Administrator Seema Verma even stated, we let the genie out of the bottle. We have to use telehealth. There's no other way around it. And we know that prior to COVID, people were really limited in how they were using telehealth because there were just too many restrictions. So they shied away from using it. And we've seen this across the board, with transitional care management. When there's too much red tape, it's really hard to use those services. But with COVID-19 and the list or the use of waivers, we were able to use those services. And so we wanted to take a look at what that utilization was. And what we see here is a huge range of utilization. Now, Maria had talked about how the cohort that we analyzed really varied. We have hospital-owned ACOs, we have independently owned ACOs, and we have some rural and SQHC-based ACOs, so a really good mix. And what the range shows here is that we even had one organization that went from 416 telehealth visits all the way up to 13,414 that year. But there's certainly a wide variation in how much it's being used. And we saw that overall, those hospital-based ACOs were quicker to adopt the telehealth practices compared to their independently owned ACO counterparts. So with all of this information, it begs the question, what can we expect moving forward? We know that across this cohort, and certainly across the entire ACO cohort, we're expecting lots of shared savings to be attained. Utilization is down. We saw that benchmarks were pretty high, and therefore the spend is down, so shared savings are available, or at least savings across the board. Now, savings may be so large that many of you will even hit your cap, and those in upside only have a 10% cap for savings, while others may have 15 or 20% cap. Now, as for those savings, ACOs will really need to think about their shared savings distribution methodologies and ensure that they're properly aligned with your ACO initiatives. The money these providers are going to be getting should be significant and should be shared in a significant way to act as an igniter for future performance years. Now, what hasn't been addressed by CMS yet is the benchmarking methodology for future years, because we know that this was an unusual performance year, so we should be on the lookout for some policy changes around that. And then lastly, let's talk about some of the consequences for that decrease in utilization. Now, a decrease in utilization is a great thing, right? Where ACOs were looking to decrease utilization, but it's not just the premise of utilization. It's specifically unnecessary or duplicative services. And we just don't think that's the case here. People just weren't using services because they were fearful of contracting COVID-19 and therefore weren't using any of those services. So we think that in 2021, 2022, and maybe some of the following years, a lot of people's conditions will worsen. And if they aren't managed properly through the use of telehealth or care management, that it's going to become even worse. And expenditures might even exceed that prior to the pandemic. So we need to really watch out for some of those exacerbations and ensure we have some initiatives in place that are going to address what's going to come down the line. Now, aside from that note of caution, we're very excited that many of you are going to attain savings this year, and even those who have been in the program for many years who didn't make money will soon actually reap benefits. So with that, I'm going to thank everyone for joining the presentation, and I'm going to give you that keyword, which is savings. So please email rmacman@salient.com, and we'll enter you to win a $100 Amazon gift card. And now we will take some questions. All right. First question was about the cohort. So what types of ACOs were included, just some elaboration on the demographics. So like I said before, we had a wide range. So some of them are really small, managed care-based, independently owned ACOs, while others were hospital-based and actually were much larger. We also have some rural FQHC-based ACOs, so it's a pretty large mix all around. And then as for tracks, they were primarily upside only, and they're all getting ready to transition into downside. So that whole concept of they're going to make some money now, but these exacerbations that are coming down the line are things to think about, because you're moving into downside risk, and you know that expenditures are going to increase if you're not managing those patients with care management and telehealth. All right. Maria, do you want to?
Yeah, I was going to say, that leads us perfectly into the next question that we got. So what has been the impact of annual wellness visits, transitional care management, chronic care management completion rates for 2020, and how might this impact quality? So interestingly, there was a pretty significant decrease in AWV, TCM, and CCM completion rates across the ACOs that we had analyzed. And this is not very surprising, especially because we saw such a significant dip in primary care services. Obviously, there's going to be a decrease in the quality measure completion rate as well. So that's going to likely impact the quality scores. All right, looks like we have one more question that came in. Do you know how CMS will be handling benchmarking for MSSP during the public health emergency for re-entering ACOs in 2022? So we don't currently have that methodology. I'm sure CMS is thinking of it. But I'm sure that the benchmarking methodology for 2022 and beyond is going to have to account for a lot of this based on the unusual performance year we had in 2020. So we'll certainly be out on the lookout for those policy changes.
And I do want to mention that we put out a blog, so anytime CMS does make a change, we will summarize it and get that out. We usually put it out on our LinkedIn page. So we'll be sharing that if anything were to change. The other question is, why do you expect savings in 2021? And is this also the expectation for 2022? So we're expecting our clients to receive savings for the 2020 performance year. As for 2021, we need to actually see what the utilization looks like and if patients are actually getting their wellness visits and going back into practices or just using services via telehealth, because the preventative services are really what's necessary to see what was missed. You know, a lot of offices closed, a lot of services were kind of repurposed or shut down. So I think what we need to do is assess how we get back to normal baseline to figure out if 2021 will actually have similar benefits that we see for the 2020 year. Maria, do you want to add to that?
Yeah, so I think just to reiterate the point, based on the data that we had analyzed, we see that in 2020, all of the utilization across the board had decreased. So based on that, the PMPY had also decreased, which will result in pretty significant savings. And of course, those ACOs will see that check in 2021. All right, and then last question is, what is the email for the drawing? So let's see if I can backtrack the slides. But it's rmacman@Salient. And I can't seem to backtrack. So if you send it to either Amy or myself on this slide, we will get it over to Ryan.
All right. Thank you so much, everyone.